Hi, good evening, everyone. On behalf of Emirates Hand Surgery Society, I welcome you all to this webinar, which is being given by a very specialized hand and plastic surgeon, Dr. Nilesh Sattai. He's also a very dear friend who works in Mumbai. He's the senior consultant and head of the department, Plastic Hand and Reconstructive Surgery at Gleneagles Hospital. He's the director of the hand transplant and vascular composite allotransplantation at Gleneagles Hospital in Mumbai. There are many things which he has done, which are part of Asia's first and India's first. It's a very long list. I will leave that list to be told by Dr. Nilesh. You all will be surprised with the amount of work he has done. He also does a lot of complex reconstructive procedures. He's a visiting professor, which is being awarded by the Association of Plastic Surgeons of India. He has done multiple fellowships, and one of the fellowships, two of them which are very important, probably are the one with Professor David Chong, with Professor Dr. Doy, and also the one which he has done in Kanga Hospital. So his areas of special interest are hand surgery, hand transplantation, reconstructive microsurgery, brachial plexus, peripheral nerve surgery, lower extremity salvage, and also lymphedema surgery. But I think today he will be enlightening us more on hand transplantation. And since 1999, when the first hand transplant was done in US, it has evolved so much that it's slowly becoming one of the most sought after, especially in bilateral amputees, where transplant definitely takes much more better outcome than giving a prosthesis. So I welcome you, Dr. Nilesh, over to you.
Thank you very much, Chaitanya, for this kind introduction. And it is my pleasure to be a part of this webinar series and to present our work and share it with all of you. So today I'm talking on hand transplantation and how it is proving to be a game changer for amputees who have lost either both their hands or one of their limbs. I always begin my talk with this special slide, which is the depiction of Lord Ganesha. Lord Ganesha is revered as the elephant god in India. And we believe that he is the first ever example of an organ transplant. So, of a xenotransplant, so to say, because he had lost his head and it was said to be replaced by an elephant head. So the roots of transplants are very deeply ingrained in all the cultures and all the societies. We find depictions of certain personalities or certain creatures which are a mix of two or three animals or which are a mix of two or three human beings. So this concept of sharing organs or transplantation has somehow been deeply ingrained in our societies and in our literature and in our mythologies. And that makes it very interesting and exciting of how this field has evolved over time. At the outset, I'm thankful again to the Emirates Hand Society for having me on this webinar. This is one of my pictures when I was in Dubai last year, and we really had a great time and we enjoyed the UAE hospitality to a great extent. I come from Mumbai. I am working as a full-time consultant at Gleneagles Hospital in Parel, Mumbai. And this is one of the leading centers in the country, and it is known as a multi-organ transplant center. So we have active transplant programs for liver transplant, kidney transplant, pancreas transplant, small bowel, heart, lung, hand, as well as certain VCAs that we are working upon. Hand transplant, I would say, has stood the test of time. It has shown good or excellent outcomes in most centers, and every system across the world has its own unique challenges in setting up a hand transplant or a VCA program. Why do we need a hand transplant? Because for amputees who are traditionally given the option of being rehabilitated by a prosthetic limb, we know what are the shortcomings of a prosthetic limb. We know that there is no true replacement for the complex and dexterous function that a human hand can perform. These processes are insensate, they cannot be used in water, they carry a certain amount of weight, there are stump related problems, there is poor or inadequate function, and the patient is seldom satisfied with the function that a prosthesis can give him. They can be exorbitantly costly, and plus they need a maintenance cost, which is a recurring expense every few years. And that all these factors actually make a person non-compliant with the prosthesis. So prosthesis is definitely not the solution for an hand or an upper extremity amputation, because it is extremely hard to duplicate the hand function even in today's advanced computer era. Of course, there are ethical concerns about hand transplantation. This is not a life-saving surgery. So there is bound to be ethical concerns because the patient is subjected to lifelong immunosuppression. This is a tremendously life enhancing procedure because this really puts back the person into the mainstream of the society. He is able to work on his own, he is able to earn his bread, he is able to live a life independently with self respect without being dependent on his basic needs on anybody else. This can theoretically have an impact of on life expectancy because of the potential problems that the immunosuppression can cause. However, we have to check out the balance in all these factors, considering of who would be the right candidate to undergo a hand transplant. That is the reason why it is a fact that liver transplants or kidney transplants today are happening on a daily basis, but hand transplants still happen once in a while because it is the patient selection that really matters the most in order to have a successful outcome from a hand transplant. For someone who has nothing, even a little means a lot. This is the basis of hand surgery said by Professor Starling Bunnell. And this is exactly the foundation on which we place the hand transplant program. We come across several amputees in our day-to-day life. They could be in a variety of forms, they could be variety of levels, they could be multi-limb amputees, they could be quadruple amputees. It is distressing to see the plight of these patients, and it is hence essential to find a constructive and a fruitful solution for this difficult problem. To begin with, I will run through how to set up a hand transplant program or how we did it, and we'll go through all the technical aspects as well as the logistical challenges that are likely to come as we aim to set up a hand transplant program. So, to assess the possibilities and preparedness, we first need to get a surgical team in place, the medical team in place, get the infrastructure in place, and to have a plan of how to run the logistics of this task. The fundamental requirements, of course, is a license from the authorities. So the institute has to be of a certain level or a standard with all basic criteria satisfied in order to procure a license to perform a complex procedure such as a hand transplant or any other vascularized composite allotransplant. It needs administrative will and support because the, the course is long drawn. The patient is under your care throughout his lifetime. As long as he is having the hands and he is on immunosuppression, he has to follow up with us at regular intervals, and we have to monitor his progress very stringently in order to ensure the safety uh, to his life and to control the potential complications that can come out of lifelong immunosuppression. We need a very well equipped infrastructure in order to perform these procedures, and we need to organize an efficient team, which is again a challenge. So the team members that are basically involved in any hand transplant program includes plastic surgeons, orthopedicians, anesthesiologists, immunologists, intensive care professionals, physiotherapists, occupational therapists, pathologists, microbiologists, and we need all other allied specialties as well who have to monitor these patients, who have to clear them to be enrolled for the program, and also for the potential problems that may come as we proceed after the transplants. In terms of logistics, we need trained assistants, nurses, support staff, the availability of staff and equipment at a very short notice because the time window when a donor is identified and the transplant has to commence can be really short at times. This involves long and odd working hours, and it requires a multidisciplinary tertiary care setup. The recipient selection, as I would underline this multiple times throughout my talk, this is the most crucial aspect, or this is the most crucial factor that determines the success of any hand transplant program. So, this could potentially be a unilateral or a bilateral amputee. The ideal recipient is a motivated adult in good general health, psychologically stable. This is one of the most important factors. He should have failed a trial of prosthetic use so that he knows the real difficulties of the rehabilitation and he knows the value of what he is getting after a transplant. The amputation mechanism should be favorable in order to be able to execute the transplantation procedure. Guillotine amputations are always better as compared to crush or avulsion or electrical burn injuries. A favorable level of amputation is always desirable because traditionally transplants have been performed at a below elbow level or preferably at a distal forearm level in order to expedite their nerve recovery and in order to get a good, fruitful function. However, our experience in this regard has been on the contrary, which I'll run through when we go through our set of patients. The donor inclusion criteria includes, they should have the consent for donation, of course. They should be of a compatible ABO and HLA type. They should be preferably of a comparable age, of similar ethnicity, of a similar skin tone, similar hair pattern, and they should not have any identifying marks. Now, this is important or this is different from the other organ transplants because hands are external organs, they are visible organs. So the physical match of the organ is really important in order to make the patient feel them as their own or so that they match or suit his body type or his body frame. So these requirements, of course, would be ideal, but the situation in reality is usually much different from this because of the dearth of organ donors. We always struggle to get a hand donation in particular, and the organ donation is an ongoing challenge for all the programs. More so for hands because these are external organs. So there is always a hesitancy from the donor family to donate the hands of their loved ones. The donor exclusion criteria would be like any infective diseases or any neuropathies or any malignancies. These are all standard exclusion criteria. The preoperative preparation begins with a workup. A detailed workup is always needed for all these patients. A detailed blood workup and immunology workup forms an extremely cornerstone of any transplant program, because it is the immunology that determines how the body would accept the transplanted hands. Would there be a possibility of rejection? If there is a rejection, how severe would it be? Would it be manageable with just titration of medications? Or at times there can be a hyperacute rejection, or over the years they might develop a chronic rejection for which there is no effective treatment. The surgical planning, of course, involves a detailed X-ray, sonography, MRI, CT angiography, and an EMG nerve conduction study in order to make the plan. Many a times, these amputees have undergone multiple surgical procedures in the past. They have lost certain critical structures in their amputated stumps. So, every case needs a detailed planning in terms of what would be the level at which the donor hands would be retrieved. How would you plan the nerve repairs? How would you plan the vessel repairs? At what level are the normal blood vessels or normal nerves available which can be repaired effectively, so that the recovery happens effectively and in a shortest possible time. Counseling and mental preparation is very important, because you need the patient to understand what he is venturing into, what commitment it takes for lifelong maintenance of a transplant. Because when they don't have hands, they are actually quite desperate to get hands. But once the transplant is done, and then they are on daily lifelong immunosuppression, and there are ups and downs as they proceed, that is when the reality check comes in. So it is our duty to give all the patients a true, realistic picture of what they are venturing into. And once they understand this and accept this, then there should be no looking back for these candidates. So the candidate selection has to go through multiple filters, and we have to really screen them. We have to really assess them in depth in order to judge their suitability to undergo this procedure. Organ donation challenges, as I said, there is a lack of awareness for VCAs. There is inactivity at all levels, because the other factor also is because these are not perceived as life-saving procedures. So there is an inactivity of sorts at multiple levels in counseling for organ donation, or from the families to come forward with an organ donation, actually. There can be financial challenges in a country like ours, where typically hands are lost of a laborer, of a working class person who may not be that financially sound. India does not have a national insurance for their citizens, so all our patients are self-sponsored. They have to bear the cost of the surgery. They have to bear the cost of the lifelong immunosuppression. So this again is an important factor that we need to figure out of how we are going to sort out this financial challenge. Fundraising has to be used effectively in order to help these patients uh, gather funds so that they are able to go through this process. There is governmental support available in some form, but the coverage is not complete. We have used crowdfunding platforms for most of our patients. We have used the help of NGOs, philanthropists, and entrepreneurs who are more than willing to give back to the society and to help these patients. So it is a challenge at multiple levels. The surgical procedures. Transplant theoretically seems similar like a replantation, but there are certain technical things that we need to consider and plan in a different manner. The length mapping or the vessel mapping has to be done so that the surgical procedure can be planned appropriately. The gross steps may seem like a replantation, but there are technical challenges in every case because each amputation stump is different from the other. And there could be size discrepancies in the bone, there could be size discrepancies in the nerves, and multiple factors that we need to figure out. And because this is a long procedure, of course the tissues develop a lot of edema at the end of the procedure, so you need to figure out of the skin flaps that would be required to cover the transplantation levels. So it is a technically complex procedure. There is a need for a skilled team. You need to troubleshoot at the last moment. Many a times, important structures or tendons could be missing in the amputation stump. So you would have to take the donor muscles right from their origin, or to create a good length of excursion for these muscles and tendons, or you would have to do a primary tendon transfer in order to gain the essential or the important functions. So you need to be innovative on most occasions in order to perform these procedures successfully, and also keeping in mind that every secondary procedure is in an immunosuppressed patient, we should be avoiding doing secondary procedures. So we should target at doing everything in the first go. So that is an important thing that goes into the planning of these procedures. And of course, we need to be prepared for failures in order to avoid them, or in order to tackle them, or in order to do a salvage in dire situations. Medical management also is crucial, because the anesthetists have to go through a lot at the time of the procedure, because it involves a large uh, tissue and volume addition to the body. There are circulatory changes, there are metabolic changes, there is an effect of the immunosuppression at the same time. So it usually keeps the anesthetists on their toes throughout the process. You need great intensive care support and monitoring, because these patients uh, go through very sudden hemodynamic changes in a very short time. So the intensive care should be extremely stringent. Immunosuppression, of course, we begin with an induction immunosuppression, which is a strong dose of immunosuppression, and then there is a lifelong maintenance dose. We need pathology support. So this is the immunosuppression regime that is followed at most places in the world. We begin with ATG induction, and we maintain it with three drugs throughout the lifetime. Of these, the steroids are targeted. The target is to get the doses of the steroids to as low as possible, because of the potential steroids periodic intervals. Of course, with time, we have realized that so many biopsies are usually not required, because hands are external or visible organs. Skin is healthy. There is fine. So this was the regime that we were initially following for the biopsies that we were performing for these patients. But later on, we are now correlating it with the clinical situation. And if the hands are clean, there's no rash, or there's no indication for doing a biopsy, we usually tend to avoid doing a biopsy. The functional outcomes of all these patients are assessed in depth in terms of the prehensile function, the grip strength, motor power, patient acceptance, the quality of life parameters, which are the most important, the resumption of work, and the psychosocial well-being. The challenges in Indian scenario, of course, are the dearth of organ donors as compared to the waiting list that we have, the myths and conceptions in the society about organ donation, and the struggle that ensues in getting organ donation in order to rehabilitate these patients, and of course the socio-economic issues. With this, we come to the next phase of my talk, where we'll discuss some clinical experiences and outcomes. This is another picture of iconic Dubai visit. So, this was our first patient. She was a young girl, a bilateral amputee following a train accident, a college-going girl who lost both her hands one fine day when she fell accidentally into the gap trap on the railway platform. and she lost both her hands. Now, imagine the plight of this girl, a young girl dependent on most of her personal and physical activities on her parents. So that really shook her confidence to a very significant level. She was withdrawn. She could not face the society, and but however, she did uh, fight it out and come out and started attending college with the help of her friends and colleagues. And she was undergoing junior college education when we met her, and we decided that she is the right candidate in order to undergo a bilateral hand transplant. We had to wait for more than 30 months after her registration in order to get a suitable donor. And the suitable donor that we got was amidst the first lockdown of the COVID pandemic. So it was all quite challenging in order to get the logistics in place to get the hands retrieved from a city which is 1,500 miles away from Mumbai, to fly them to Mumbai and to arrange the logistics. So the logistics involves four teams working at the same time in order to prepare two hands of the donor and two hands of the recipient. And then we narrow down to two stations where we are attaching the limb and reperfusing and then repairing all the essential structures. And we could perform this transplant successfully, and rest, as we say, changed the outlook of the program entirely. She became one of our important ambassadors of the transplant program. She uh, worked very hard on her rehab. She could gain all these milestones within 18 months of the transplants. As she could take care of all her personal activities. She the One thing that we did is we provided her employment at our own hospital, where she now works as a patient care coordinator. So she is helping out patients. She is working independently. She's traveling independently. She's doing most of her activities independently. And today she's a changed person altogether. So these are some of the activities of her at at her desk, coming to the hospital, opening the doors, writing or using a keypad, or going through the patient files. So the idea is to make these patients a part of the normal society. They should not be looked upon as different. They should not be looked upon as somebody with a different ability. So their working and functioning should make them an integral part of the society. This was our second patient, who was a quadruple amputee. So there are a new set of challenge that we faced in quadruple amputees, is that because of lack of both upper and lower limbs, the blood volume, or the area to which the blood circulation is quite restricted in their amputated state. And then suddenly there is an expansion of the blood volume, which leads to certain specific hemodynamic challenges in their postoperative phase. So this was again a bilateral transplant. On one side, we did it at the proximal forearm level, and the other at a supracondylar level. And this was the first successful quadruple transplant in a quadruple amputee in India. And this, you can see, 11 months later, he's back to most of his activity. He's living a normal, productive life today, and we were happy to help him regain back his function and support his old parents at his village. They will always have some deficits in terms of intrinsic function of these hands, but the idea is to make them functional on a day-to-day basis, rather than looking at the finer aspects of the function. Because from where they start, they begin from a very dependent situation. So, in order to make them independent, or in order to make them do all their activities on their own, is what we mainly target, or we mainly aim at. So you can look at his face, or his confidence, or his outlook towards life has completely changed. He was a very depressed and indrawn person when he came to us. Our third patient again was a quadruple amputee, an elbow level amputee who lost his hands during a freak electric accident. He again went a bilateral supracondylar accident, and these transplants, these are our three patients together, two of them which we performed within a span of 15 days between each other. And then he's celebrating the festival of Makar Sankranti. He's flying a kite. So the idea is again, from where he began, he is today a much different man. This is a young lady, again a bilateral proximal forearm and elbow level amputee. She was extremely depressed after losing her hands because she could not take care of her young children. She could not take care of her husband or do her household chores. And she underwent a bilateral transplant, again, one on the proximal forearm, the other on the supracondylar level. And she was extremely happy to take care of her kids and to take care of her family. These are two special cases. One, the case number five, we have performed a partial hand transplant in which, on the right hand, if you see, it is just the three fingers which are missing, the index, middle, and the ring finger. And on the left hand, it is, of course, a mid forearm level amputation. So on the left forearm, we did a transplant at the proximal forearm level. But for the right hand, we did a transplant just for the partial hand, just for the index, middle, and the ring fingers. So this is Asia's first partial hand transplant. And the girl on the right side, you're seeing a girl with a congenital aplasia of the hand. So a transplant in a congenital aplasia again is something which is not much known to the transplant world as well. But this girl was extremely determined to have a hand, and she was willing to go for the extra mile to make it a success. And today she's back to her routine life. She's back to her college, and she's able to use the transplanted hand effectively. This was another special case, a very proximal level amputee, almost at the proximal humerus level. It was just an empty stump, so to say. It was just the bone in the stump, and all the other structures were missing. So practically, we had to go almost up to the infraclavicular level or under the clavicle in order to repair the subclavian vessels and to repair the nerves at the level of the brachial plexus. And 4 months back, 4 months post his transplant, he began to get his elbow flexion, and he also began to get his hand function very soon. So this is the function which started 12 months post transplant, almost at the level of the shoulder. So it is a still a faster recovery as compared to what we would see in a shoulder level replant. And of course, his recent function is even more better than this. This was another patient with a bilateral amputation at a variable level. Again, extremely scarred stumps. The stump on the left side, though it seems to be at an elbow level, but the structures, healthy structures, were available only at a proximal arm level. So they live a compromised life before the transplant. They learn to use their feet for most of their activities, or to keep themselves entertained. But life after transplants is much different, and then they're very happy to go back to work and to take care of their families. Fortunately, in our series, we encountered extremely few episodes of rejections. So, of all our patients, only three of our patients actually had rejection episodes, which we were able to manage with the titration of medications. The complications encountered were also relatively fewer as compared to the world data. The most major complication was a CMV pneumonia in our third patient, and a transient or a prolonged neutropenia in our fifth patient. So practically all of them are today living a reasonable, independent and fruitful life. Till date, we have done transplants in 13 patients, 9 of which were due to electric shock or electric accidents, 2 due to train accidents, 1 an industrial accidents, and 1 was in a congenital absence. Of these 13 patients, there were 9 males and 4 females, 11 bilateral and 2 unilateral transplants. So 24 hands in all. Of the 24 hands, the 8 were of proximal forearm level, then 4 were supracondylar, 1 was mid-arm, 1 partial hand, and 10 at proximal arm level. So these are certain pictures of patients who have undergone transplants. So transplant, I say, is the ultimate legacy that a person can leave, and it is the greatest gift of community service that we can give. Of course, this involves a huge teamwork and arranging the team because we work in a private setup. So some of our team members work in different setups, and they come down for the transplant surgery, and it is all a collaborative team effort. We stand on the shoulder of giants. The experience in India and outside India has definitely helped us a lot in order to build this program. I would mention my teachers and mentors, Professor Baliar Singh, Dr. Doy, and Dr. Raja Sabapati, who have mentored me at every stage. I would like to say, in terms of India and UAE, considering our special ties, hand in hand, we will work to strengthen the social bonds, foster the shared responsibility, and unlock potential for inclusive and sustainable growth. And this is a statement of none other than your own president, MBZ. So I look forward to opportunities to collaborate with all of you. Transplants are complex programs which can be built with multi country or multi continent collaboration as well, and we can definitely look into these prospects for the future. With this, I would like to welcome all of you to the APFSSH meeting, which is in September 25 in Mumbai, and we would love to host all of you. India is a colorful country. It has something to offer to all, including the mighty Himalayas, or yoga, or temples, or wildlife, or beaches. There's something of everything for everybody in India. Thank you so much.
Thank you, Dr. Nilesh. That was as concise as it can be for a very complex topic, and making it crisp so that a lot of people can understand. Uh, I would like to know, uh, depending on the level of transplants you have done, which could have been, which was the most, probably the easiest, or which were the most difficult, depending on the levels.
Mm. Yes, so considering the number of structures that we need to repair, a distal transplant actually takes a longer time because the number of tendons to be repaired is much more. But
Right.
the better part of a distal transplant is that the ischemia time is not much of a concern because of the limited muscle mass in the distal transplants. Now, unfortunately, for some reason, in our entire series, practically we are even after 13 transplants in, 13 patients, we are yet to do a proper distal forearm transplant. All our transplants have either been mid forearm or proximal forearm or supracondylar and above. So the only transplant was the partial hand, which is again a very complex area in terms of the arches of the hand or in terms of the intrinsics. So it was the dissection of that partial hand was extremely complex and challenging
Right.
actually. And in the proximal transplants, of course, you struggle for space. So you need to reach a healthy level where, because right from the shoulder, there is a huge amount of muscle mass that is being transferred. So
Right.
the revascularization has to be very fast in order to prevent the ischemia and the reperfusion injury. And at the same time, you need to go at a healthy level of blood vessels. So which is typically you need to struggle under the clavicle in order to get a good volume or a good size of blood vessel. And that
Right.
it makes the vessel control challenging at times, or the repair under the clavicle challenging at times. So, but then once the vascular anastomosis is done, then the number of structures that you have to repair are relatively lesser.
Right.
So there are the challenges in both the situations are of a different type. But distal
Right.
transplants are of course simpler, but we haven't really done a distal transplant yet.
One more thing, what I noticed is in some of your arm or shoulder level hand transplants, you said that the recovery in the function of the hand was much faster than a reimplanted similar level. Do you think is there any correlation of this because of the immunosuppression you give, that the
Yes,
nerves recover faster?
yes. So as I said, that tacrolimus actually is neurofacilitatory. So the nerve recovery with tacrolimus is always faster. So so that it is the tacrolimus that helps in the faster nerve recovery.
We have a few questions. There is a question which asks if you can comment on the regain of function of the transplanted hand.
On the
Transplanted hand.
function.
Yes.
So the extrinsic function is always faster to recover, and they do get good extrinsic function in a very short time. The intrinsic function, you always have to struggle for getting the good intrinsic function. Among the intrinsics, of course, the median, as always, recovers faster than the ulnar, and it is the ulnar intrinsics that we many a times struggle. So we have to keep them on claw correction splints or for thumb abduction splints for a very long time till they get function. But in all our patients. Some of them are have got good intrinsic function as well. Some of them who have not got the intrinsic function as well are pretty well adjusted, and they do not want any secondary surgery, or even we are not keen on any secondary surgeries in these patients, or we feel that secondary surgeries in transplants should be avoided or delayed as much as possible, because every injury can act as a trigger for rejection, because it tends to act like a surgical trigger, or it tends to uh, act as an inflammatory source to the body, and that can trigger a rejection reaction, which we then have to tackle with adjusting the medications. So that is our thought process behind delaying any secondary corrective procedures for these patients. And many times they do get, though delayed, but they do get intrinsic function.
This immunosuppression which you do post-transplant is mainly managed by immunologist, or will you also involve directly into?
No, so practically, as surgeons, our knowledge and exposure to immunosuppression is quite limited, and immunosuppression actually is quite complex and vast for a surgeon to master. So we have better skilled people around, and the nephrologists who manage the immunosuppression for kidney transplants manage the immunosuppression for hand transplant patients as well, because the basic framework of the immunosuppressive therapy is similar for a kidney transplant and a hand transplant.
Now, in one of your criteria which you mentioned, for a recipient, he needs to have a failed time of use of prosthesis. By this, you mean the mechanical or the manual ones also?
No, so the idea is that previously it was said, I mean, it is the literature does not mention any specific type of prosthesis, but the idea behind it is to understand the futility of a prosthesis, or to understand the limitations of the prosthesis, because on a human level there are besides science, there is a lot of human, social, psychological, emotional aspect involved in a transplant, in an organ transplant. The way the human mind perceives things, the way the human mind values a thing. When a transplant is being done for a life-saving organ, then the approach or attitude of a person is much different than when it is done for something which is life enhancing and not life saving. So there is a lot of mindset or a psychology that goes of the patient that we actually need to assess before choosing them for a transplant, and in order to make or keep them motivated throughout their life in order to maintain the transplant. So the idea behind the processes used is also just to understand or realize how disabling it is not to have a hand, and to understand how uh, compromised the option of prosthesis is, so that they accept the transplant in a better way or in a better mindset. That I think is a probably a non-scientific reason uh, of getting the patient in the right frame of mind in order to accept and maintain the transplant uh, in the long run.
I think we have one question which asks, in the proximal transplants you did, what were the challenges you faced with regards to nerve cooperation?
So the nerves basically are almost at the level of the peripheral branches of the plexus, or at the divisions of the plexus. So you need to identify the healthy nerves. Typically, they develop very large or thick neuromas at that level because the nerve size also is significant. So when the nerve, a major nerve is cut at that level, they tend to develop large neuromas. But the amount of vessel damage is usually much more than nerve damage, because majority of our patients in whom we have done a proximal transplants have had sustained electrical injuries. So a high voltage electric current, when it passes through the body, it is going to scar all the structures. Nerves are, we feel, are relatively resistant to this electric current. So the nerve damage is always slightly distal as compared to the vessel damage. With the vessels, because being hollow structures, they tend to scar much more, or they tend to contract in size. So getting a healthy sized vessel has been a bigger challenge than getting a nerve.
Then one more thing which is specifically mentioned with regards to donors is that there should be no identifying marks. By this, you mean that the donor should not have any scars, or with the present generation you have, I think it's very difficult to find people who don't have tattoos on their hands.
Hmm.
So, if you have a donor with a tattoo, do you mean to say that that is acceptable?
No, so the criterias are you mean there is theory and there is practice. So theoretically, these are the ideal criterias for a donor. But practically, when we don't have a choice, or when there is a precious donation happening, then you really have to weigh the options of whether to let go a donation for such a reason, or to accept it and move forward. So some of our recipients also have continue to have the tattoos of their donors actually.
Correct.
So we have not followed that I mean rule very strictly, because we feel that uh, when there is a immense shortage of organs, missing out an opportunity for such a trivial cause, for that matter, should is definitely avoidable. And on a personal level, actually, though we do not disclose the donor and the recipient identity to each other, but these transplants happen so far and few that they always make a lot of buzz in the media, or they make a buzz in the newspapers. So eventually, the families, they end up knowing whom their hands or organs have gone to. and
True.
and
It's
many a
not,
times
yeah,
and
it's
many a
not
time
as common as renal or liver
Yes,
transplant, isn't it?
yes. So they on certain instances, the families have connected with each other on their own, and it is really gratifying, or it is a different feeling of seeing your loved one's hands on somebody else's body. You can touch them, you can see them move, you can feel them. So it is emotionally, it is at a much different level. So,
True. True.
I mean, and that really has helped in a way, in order to create awareness, or to improve the understanding of the society, or to improve the acceptance among the society for these kind of procedures.
I think recently in one of the discussions I happened to see, correct me if I'm wrong, that the biometrics of a person before he had an amputation, you know, and then he had a transplant, even though the transplanted hand was from some other patient, I mean, some other person, the biometrics matched what he had before. Is that true or?
So there was a news article which conveyed that kind of a message,
Okay.
which was actually very surprising for me as well, because I went back and checked the literature. So the possibility of two people having the same biometrics is 1 in 64 millions or 64 billions.
Yeah.
The possibility of two-person having the same biometrics, which is extremely rare. So I actually felt that I mean, we should really study the fingerprints and see whether they're actually similar, or whether the biometrics is picking it as a minor error and it is being missed, which is theoretically it is not possible for two people to have the same fingerprints.
Yeah.
But yeah, it was an interesting news article, and actually we need to find out the truth behind it.
Okay. Now I think we don't have any more questions. One question out of this topic, from what I see, is a lot of people who do these complex reconstructions over the world. They are either half marathon runners, or do crazy heights, 5,000 meters, 6,000 meters, and I know you do a quite lot of them. Is there
Yes.
any relation between people who do those and do these complex reconstructions, or what?
Uh, no, I'm sure that actually it is just been a passion actually. So I run as and when I get opportunities, and then yeah, I mean it is now I've tied it up with my passion of creating awareness for organ donations. So every marathon I'm carrying something to create awareness about organ donation, about hand donation, or on every hike I'm doing this. So, but yeah, it is a good habit or a good hobby because especially we have very tall, we have the mighty Himalayas in our vicinity. So every year we take that opportunity of going in for a high altitude trek, and it really rejuvenates you, or it cuts you off from the your off network for a couple of days, and you get a lot of time to think and rejuvenate, and then you come back fresh and begin your work again. So
Yeah,
it's been a great habit plus a great refreshing change.
great, great to know.
And I see you running as well.
Yeah,
So
yeah, once in a
so
while.
so I'm sure the hand transplants program are about to begin in UAE as well.
Yeah, we are working on that, honestly. So maybe I'll get in touch with you also for more guidance, and we'll see how it goes from there.
So definitely, actually, there is a lot of scope for collaboration because the collective knowledge. I mean, the transplant the society is a very small and cohesive group actually, and the we have all learned from the collective knowledge from each other's experiences. So there is definitely a lot to share and learn. So definitely, we can explore the possibilities of collaborating on this.
Okay. Okay. I think we don't have any more questions. So I would like to thank you, Dr. Nilesh, for taking out, almost an hour or more than that. And I'm sorry for the small glitches we had in between the presentation. There were some technical issues, but I think all in all, we had a great seminar, great webinar rather. So thank you very much.
Thank you, and I hope that I could contribute in the right manner to share the knowledge and to inspire some more programs to come up.
Yeah, we will.